Well, thank you very much for asking me to come here today and for the lovely welcome to the country. And Sue, thank you very much for reminding us why many of us in this room battle for the same issues that you're battling for. It's terrific to put a human face to this issue rather than just deal in abstract notions. And I'm afraid my talk is going to be more at the other end, dealing with sort of abstract stuff. I hope not too much. I'm going to say a little bit about the history of needle syringe programs in Australia and then talk a little bit about the role of discrimination, it says against people who inject drugs and people who use drugs without injecting. And it's a real battle. Okay, the history of needle syringe programs goes back, I guess, to 5th of June 1981, when the Centers for Disease Control, and now called the Centers for Disease Control and Prevention in the United States, announced the detection of what they thought was a new epidemic of people with acquired immune deficiency disease. They reported 5 cases, 2 or 3 of them had already died by the time they made this announcement. We now realise that epidemic had been going on for decades, many decades before that announcement. We didn't know that at the time. What we found out a few years later in Sydney, a group of researchers, David Cooper, Ron Penny, Julian Gold, estimated that there were about 3,000 to 4,000 men who have sex with men who had become HIV positive. Not sure whether we used that term when they made this study. In a small area in eastern Sydney, if those of you know eastern Sydney, between Taylor Square and King's Cross, that kind of area, over a 12 to 18-month period in the early 1980s. When I heard about the result of this study, I got a panic attack, and I could see this cascade of HIV infections going from men who have sex with men to men who have sex with men and also inject drugs, going to people who inject drugs who are not men who have sex with men, and then going to the general community, what we call a generalised epidemic, when more than 1% of the general community have HIV. And generalised epidemics have occurred in a number of countries, half a dozen to a dozen countries, depending on what definitions you use, starting from people who inject drugs. In 1987, we had such an epidemic starting in Thailand, the first epidemic, generalised epidemic that we knew of in a developing country that started from people who inject drugs. In fact, it started in the prison system in Thailand, and nobody knew this was going on, and the king turned 60 in 1987, and there was a royal amnesty. Many prisoners were released, and HIV went from less than 1% to over 40% among people who inject drugs in the community over a 10-month period. So it went up 4% a month for 10 months. And then within a few years, 16% of male military recruits and 12% of pregnant women in the northwest of Thailand, around Chiang Mai, that kind of region, had HIV, all from an epidemic starting among people who inject drugs in 1987. So these things happen all right, and they're a real risk, and a group of us were terrified this was going to happen in Australia, and I was terrified this was going to happen on my watch in the neighbourhood that I was supposedly responsible for. And so I looked at the gay community in Sydney, in Australia, and they were galvanised into action overnight. Their campaign for homosexual law reform overnight morphed into a campaign to respond to HIV. And the leaders of that community who were not performing were found in a ditch the next day, and someone who could perform was put in their place. They really took this threat very seriously, and thank God they did. And I looked at the community of people who inject drugs and wondered, was that going to happen among people who inject drugs? So a group of health workers and a group of people who inject drugs got together, formed a group, were called by a policeman, Frank Hansen, ADDIC, the AIDS Drugs Information Collective. And we used to meet every few weeks and figure out how the hell we were going to stop this epidemic of HIV spreading among and from people who inject drug users to the rest of the community. And it seemed very quickly that there were 4 priorities. And the first priority was to start educating people who inject drugs about the risks they were facing from HIV. The second was we fairly quickly realized that needle syringe programs were critical. And then the expansion and improvement of opioid substitution treatments, as Sue's already talked about, was the next priority. Later on, organising communities of people who inject drugs became a priority. And NEWA, Grace Atler and I started NEWA in 1989 as part of all of this, the New South Wales Users AIDS Association. In 1984, the Municipal Health Organisation in Amsterdam started, and it's called GG&D, GG&D. It started a needle syringe program in Amsterdam. And the idea of that came from drug users. And the health authority first rejected it, and then they accepted it. Meanwhile, something had been going on in Scotland. A Glasgow pharmacist had decided on his own bat to start providing clean needles and syringes to stop hepatitis B. That had been going for a while. Health department heard about it, closed it down. But in Protestant Edinburgh, there was no such joy, and so needle syringes were never available in Edinburgh, and that story is also important. So in 1985, Norman Fowler was the health minister in Margaret Thatcher's government, and he went to the Prime Minister with the plea that that Britain should start a needle syringe program. And famously, he's supposed to have said to Prime Minister, Mrs. Thatcher, we should do this in Britain because it'll cost a lot more money if we don't do it. And she liked that argument. And Norman Fowler, still alive, great man, saved a lot of lives. And that example of Britain ricocheted around the world. And what happened in Scotland was that a general practitioner in Eastern Edinburgh, Roy Robertson, was doing a study of patients in his practice. He had 151 people who inject drugs who were his patients, who he was following, looking at hepatitis B. He'd collect blood samples from them. And he heard about this HIV test, and he ran the HIV test on his patients in his practice. And he found that the prevalence of HIV went from 1 to 51% in 18 months. And he wrote that up in the British Medical Journal, and it was like a nuclear bomb exploding. The Scottish Blood Bank, understandably, was alarmed, conducted an urgent inquiry, and within a couple of months issued a report that said we have to regard the problems caused by drug use as more urgent than drug use itself. And then that was taken up by the official advisory body, the Advisory Council on Misuse of Drugs, the ACMD, that issued a famous report. And this ricocheted all around the world. And we started using all of that back in Australia. I started writing submissions. Grace Atler, some years later, working in the health department, told to clean out a cupboard, came across, I'm ashamed to say, 13 separate submissions by me. Okay, I'm a bit obsessive. And every single one of those submissions had been ignored or rejected. This is too long, can you make it shorter? This is too short, can you make it longer? You're asking for too much money, you're not asking for enough money. You've got too many references, you haven't got enough references. That's that kind of thing. Carla knows all about this kind of stuff. Finally, on the 12th of November, 86, I got the bright idea that they're never going to say yes. You're going to have to do it. And so a group of us, including Gino Bimbucker, Kate Dolan, some others, started a pilot needle syringe program in Darlinghurst. It was actually in St Vincent's Hospital property. We did it with our own money. We were very careful to make sure that we didn't use a cent of Department of Health money, and we didn't. And we put a note on the door saying, if you want clean needles and syringes, press the buzzer. And nobody came that day, but they started coming the next day, and they haven't stopped ever since. And we distribute about 40 million needles and syringes a year in Australia, and it's really worked. I got, and this was a group activity. I was the kind of front guy, male, doctor, specialist, Catholic hospital, so I could do all this stuff and get away with it. Female nurses, not a chance. So I did the media, and police came to interview me, group of detectives, and so I spoke for about 45 minutes without pausing for breath, telling them what was happening to HIV in Geneva and Milan and New Jersey and Connecticut and New York and all the rest of it. And then at the end of it, they said, we're not going to charge you. We didn't actually want to interview you. The police minister insisted that we did, so we've interviewed you. And as soon as I heard those words, I knew we'd won. And that before the end of the year, the New South Wales Cabinet had approved needle syringe programs, and then within 2 years, every state and territory in Australia had a needle and syringe program. So that's how it all began. Well, no, it's not a good story. It's not a good story. This is a terrible story because this is about discrimination. Would they have done this for any other group? No. They did this to us. They made us jump cartwheels. They made us jump cartwheels because we were trying to protect people who inject drugs. And I didn't really realise that year. It took me a little while to realise that. 50% of the needle syringe programs around the world had to start, so it's estimated, by civil disobedience, just like we had. So it's not a good story. It's a terrible story. The needle syringe program has been expanded and improved ever since. And the good news is that HIV prevalence among people who inject drugs in Australia is still very, very low, 1 to 2%, that sort of range. And it's remained low, and the number of new cases of hepatitis C per 100 drug users, the incidence of hepatitis C has halved in the last 15 years, still going down. So it's been a huge benefit. In money terms, in 2009, the Commonwealth Department of Health commissioned a study which was done by reputable people, and they estimated that just in the decade 2000 to 2009, 32,000 HIV, 100,000, rounding off the figures, 100,000 hepatitis C infections had been prevented just in that decade. And the saving, wait for it, was between 2.4 to 7.7 billion dollars. Billion with a B, for a cost of $240 million. Now, that's a good result, a pretty good result. That's just for 10 years, and of course this goes on and on. So we've had tremendous research support, and Carla is part of that. In 1987, I was sitting in my office one day and thinking, not something I do very often, and I thought, hang on, why did we have to do all that? Here we had a threat that everybody said was real and was serious. We had this cascade of HIV infections that could mow down lots of people who inject drugs, and lots of the general community who don't use drugs. And that was a serious health, social, and economic threat to the community. No question about that. Everybody accepted that. Everybody accepted that my group that I was part of, was critical to doing something about that because of our geographical location and where the big drug market is in Australia, the biggest drug market in Australia. So nobody questioned that. But they said, you can't do it by this method, you've got to find some other way of doing it. Now, that's crazy. Why are they doing this to us? And then I realized that the main barrier to needle syringe programs all along had always been our drug policy, our commitment to our drug prohibition. And so I started to ask myself, does this policy, what is this policy? Does it work? How much does it cost? What are the benefits? Those sort of things that researchy people like to do. Now, I had a very hard time during this period. A lot of people thought I was seriously nuts. A lot of my colleagues, I was very marginalised and ostracised, like drug users are all the time. I didn't realise that. And so I took 3 months sabbatical leave, which I was able to do. And I went to Western Europe, Switzerland, Netherlands, and Britain, and North America, Canada, US, to look at how those 5 countries were responding to HIV among people who inject drugs. And I'd met the Deputy Director of the Bureau of International Narcotics and Law Enforcement Affairs, as it's now called INL. I'd met him when he was visiting Sydney, and he had said, if you come to Washington, D.C., come and see me. So I did come and see him, and that office was in the US State Department. And so I went to see him, contacted him, went to see him, went to, I think it's 6th floor, and there was this impressive corridor. I walked down the corridor, and the right-hand side was a green marble portico over the entrance to the office of the Secretary of the State Department, George Shultz, and right opposite was this office, the office of INL. Now, as you know, in Washington, D.C., location is everything. So if they put INL opposite the office of the Secretary, that's significant. So I went in and I was talking to this Deputy Director, and I asked politely, I said, I'm starting to have some doubts about drug prohibition. Does it really work? Can you give me some evidence that it really does something positive and that's really worth it? And his response was as follows. He said to me, in the last 12 months, the US dollar has depreciated against all our major trading partners, and the US State Department does most of its business outside the United States, so our cost of doing our work has just gone up hugely. So we had to revise our budget, and every section of the US State Department was cut except 2, Embassy Security and INL. And I waited for follow-on, and there was no follow-on. So what he was telling me was, listen, guy, doesn't matter whether this program works or not, bureaucratically it works, and that's all that matters. That's what he was really telling me. So that made a big impression on me. Later I was in New York, and I contacted a wonderful Puerto Rican nurse who unfortunately a few years later died of AIDS, and she'd caught HIV from her husband who had been on the methadone program that she worked on. And asked Yolanda she'd visited Sydney and met me and said, when you come to New York, look me up and I'll take you to Macy's, Bloomingdale's. So when I got to New York, I said, Yolanda, I want to go to a shooting gallery. We don't have shooting galleries in Australia. I want to see a shooting gallery. No way, I'm not taking you to a shooting gallery. I go to shooting galleries, you're not going to come to a shooting gallery. Forget it. No, Yolanda, I'm not interested in Macy's, Bloomingdale's, the Empire State Building. I want a shooting gallery. So she took me to Shooting Gallery in Williamsburg, Brooklyn. And I'm very glad she did. Thank you, Yolanda, because it changed my life. And it changed my life sitting watching two Hispanic men, two Hispanic women shooting speedballs of heroin and cocaine all night. And I don't speak Spanish, they didn't speak English, someone agreed to translate. We had a little conversation. Have you heard about AIDS? Have you heard about AIDS and drug users? Do you know any people with AIDS? Do you know any people who've died from AIDS? Do you know any people with, who got AIDS from drug use who've died? And when I got to that question, the guy said, "Tell this guy to shut up," in Spanish. So I dropped the conversation and I just watched them. And their lack of any attention to preserving their health, it was so shocking to me that I realized, you know, there had to be some explanation for it. And then it slowly dawned on me, these guys have had shit lives. Their lives are never going to get better. They know about persecution and discrimination. They're experiencing it. They know their kids are going to have just as shit lives and their grandkids are going to have just as shit lives. Why wouldn't you have 4 hours of a chemical vacation, go somewhere really lovely, have an enjoyable experience when your whole rest of your life, your short life, is going to be shit? So I learnt that night just how important the social factors are in drug use, something we try to ignore completely and do a very good job ignoring completely. So let me ask the question, does our current drug policy work? Well, the drug market here in Australia and overseas over the last half century that we've been prosecuting the war on drugs, drug production up, drug consumption up, number of different types of drugs up, the dangerousness of the more recent new drugs up, price of drugs down, 80% fall in heroin and cocaine prices over the last quarter century, for example. Other drugs have also generally fallen in price. Purity of drugs has stayed the same, in some cases gone up, many cases gone up. Drugs were always readily available and they're still readily available. Now, those things are important, but these things, in my view, are even more important. The outcomes of drug policy. Deaths are up. Disease is up. Crime, property crime, violent crime, both up. Corruption, hard to measure, probably up. Threats to national security, yes, threats to national security. Things like Afghanistan and Pakistan falling over, so we send troops over there. Mexico imploding next to the United States. Not good for the United States. So threats to national security definitely, in my view, are up, connected with this issue. Have there been any benefits? Yes, there has been a big benefit. Bad policy is good politics. So this policy has gone on. Now, all of this stuff that I've just gone through, this slide and the last slide, you'll find a lot of the data for that in this article. If you're silly enough to want to read it, you can get it online for free. And in 4,000 words, I couldn't put in all the data I've got, not even 10% of the data I've got, to make all of these points. Trust me, there's data for every single one of those things I've said. Are there better options? Yes, we have to redefine drugs as primarily a health and social issue. That is the threshold question, and we have to make that switch. And once we make that switch, a whole lot of other things follow automatically. It means that evidence becomes important. It means that human rights becomes important. It means that we spend money to try and get a return on investment. All of those things happen. And part of that process is what people call decriminalizing drugs. Not a term I like, but anyway, people use that term. And we have to also regulate as much of the market as we can. Now, that may seem a crazy notion to you, maybe it is, but the needle syringe program is partly regulating the market. The opiate substitution treatments Sue talked about, partly regulating the market. Medically supervised injecting centre, yes, we've only got one after 15 years. National disgrace. Only one since 2001. yes, that's partly regulating the market. We have to do much more of that kind of thing. And we also have to shrink severe poverty. If you have a lot of people living like those 4 Hispanic people I mentioned that I met in 1987 in Williamsburg, Brooklyn, if you have a lot of people like that, you're going to have a big drug problem. So what's the most critical question? If whether our drugs policy works or not is an important question, but not the most important question. If the question of whether there are better ways of managing this is an important question, but not the most important question, what's the most important question? The most important question is whether our drug laws are fair and just. That's the most important question. Absent harm to others, are our drug laws fair and just? In other words, if somebody's not harming somebody else, is it fair and unjust to punish them for using a drug that you mightn't like or the person sitting next to you mightn't like? Now, all over the world, the countries take the question of punishing their citizens for wrongdoing very, very carefully, for good reason. So they spend a lot of money, a lot of effort and energy goes, believe it or not, into trying to have good laws and to have a good legal system so that people are given a fair trial and appropriately punished if they're convicted. And yet we have these things like Oscar Wilde getting a 2-year prison sentence with hard labour for having sex with another man. We have Alan Turing given the option of, in 1952, of having a prison sentence or going on a female sex hormone because he was convicted of having sex with another man. Who's Alan Turing? Oh, he's that guy that shortened World War II by 2 years by cracking the Nazis' communication code. He's that guy who made so much of a contribution to computers that we all walk around with iPhones and iPads and computers. You know, we'd still be using typewriters if it wasn't for Alan Turing. But in 1952, he got the option of prison sentence or stilbestrol. He chose stilbestrol, couldn't hack the idea of walking around with female breasts, and so he injected an apple with strychnine and took a bite out of it and committed suicide. And some people believe that the icon that Apple uses, that Steve Jobs chose, of an apple with a bite missing out of it, is a reference to Alan Turing. Now, a lot of people were very upset about the way Britain treated Alan Turing. A lot of people in Britain were upset about it. Just a few years ago, the Queen exonerated him and admitted wrongdoing by the state. But in 1957, the Wolfenden Committee was established to look into homosexuality, and they came out with that famous phrase that we shouldn't have criminal sanctions for people who have consenting sex in private with a person of the same sex. That was 1957, and look how long it took after the Wolfenden report for things to happen. Social policy reform is very slow. We now increasingly accept around the world that for the heterosexual majority to punish a minority of people who prefer same-sex sex is barbaric, and surely it is. Now, if that's barbaric, why isn't it barbaric when we do exactly the same thing with drugs? And of course it is barbaric. So how are we going to reduce discrimination against people who inject drugs? Well, I think one of the first things we've got to do is learn from the gay community. So people who use drugs and come out, using the phrase that gay law reform used, that helps. They've got to be brave people to do it, and I salute the people who do that, like you, Sue, you Digby, who've come out and spoken about that. And Eddie, who may be here tonight, I'm not sure she is, Eddie Lloyd has also done that. She did it in a fairly private way on page 1 of the Sydney Morning Herald. Condemning discrimination helps. And let me just give you a little anecdote about discrimination against people who inject drugs. A friend of mine in San Francisco, Marsha Rosenbaum, who's well known in the US for this kind of work, did a study some years ago which became a book. It was called Surrender to Control, a wonderful title, interviewing people on methadone programs in San Francisco. One of the people she interviewed was a very successful transsexual who had made the transition, and hardly anybody spotted her, that she was a transsexual. And so Marsha was interviewing this lady, and the lady said, all my friends know that I'm a transsexual and that I started off as a man and made this transition to a woman, but I've only told a few people, just a very few of my very closest friends, that I'm on a methadone program. How's that for discrimination? Pretty good, I'd say. But, discrimination isn't just something that affects the people who inject drugs. It affects everybody in the community. It affected me because I was somebody who provided health care to people who injected drugs. I'm retired now. But I did that for 30 years in Sydney. And, of course, we were discriminated against because we were shit doctors who couldn't do anything better than look after people who, these lepers in our community. So it affects all of us. If we do bad things to people, it affects everybody else in the community, not just the people who get discriminated against. Of course, the people who get discriminated against are affected much more. So that's probably time for me to wrap up. Australia and other countries faced a very serious threat from HIV, and we responded to it much slower and with a much smaller response than we should have. And the main obstacles that I've explained to you, in my view, was the entrenched commitment to global drug prohibition. That is the root cause of all these problems. Just to give you an example of how slow this response is, and it's still a problem today worldwide. We did pretty well in the battle against HIV with most groups at risk of HIV around the world. HIV, number of new cases of HIV is, in many parts of the world, is falling rapidly. But guess what? It's not falling among people who inject drugs. They set targets for it. Men who have sex with men, men and women who are affected by heterosexual sex, people who inject drugs. They set targets for all of these things. And the worst performance was among people who inject drugs. We missed our targets by 80%. 80%. That's outrageous. And why did we miss our targets by 80%? Because of discrimination. So discrimination has a health cost for people who inject drugs. Discrimination has a health cost for people who've never been near injecting drugs. And people who inject drugs bear the brunt of these health costs, but other people do as well, like this lovely lady, Yolanda, who I met here in Sydney, later on in Williamsburg, Brooklyn. Drug laws are ineffective, counterproductive, and cost ineffective. There are less worse ways of managing this problem, but they're not the real problems with our drug policy. The real problems is that the laws are unfair and unjust. And who amongst us would support unfair and unjust laws if they did work, or if they were the best way of managing things? If laws are unfair and unjust, we shouldn't have them. Get rid of them. We need drug law reform now, and I put the last dot point there in Latin, as you can see, ceterum censeo Carthaginem esse delendum. My father used to say this, scholarly kind of guy, and this was said by Cato the Elder in every speech he made, and so saying Carthage should be destroyed. He wanted Carthage gone, and I want drug prohibition gone. I'm that guy who goes, whatever, whether I'm talking about global warming or whatever, I want drug prohibition gone. So that's why I ended on this note. And I hope what you will do is take this on in your lives. I hope you will let your members of Parliament know what you think about our drug policies. I hope you will write letters to the editor. I hope you will write op-ed pieces. I hope you will ring up talkback radio, and I hope you will work so that we can move on to drug policies which are fair and just and which work, and which don't engender discrimination as these ones do. And the sooner we can move on to those new drug laws, the better. Thank you all very much for listening.